Good morning, everyone, and welcome. I am Guillermo Martinez, the Deputy Director and Intergovernmental Liaison for the Institute on Immigrant Integration, Research, and Policy at the Rockefeller Institute of Government at the State University of New York. We are honored to have our distinguished panelists and speaker join us this morning, and thank you all, our webinar attendees, for joining us and representing institutions of higher learning, nonprofit sector, the legislative branch of both our state and federal governments, and the advocacy community. This forum is being recorded and the video will be made available on our website and YouTube. We invite you to join us on May 22nd for our annual conference on immigrant integration in New York State at the University at Albany. Registration information will be available soon for this free, in-person, and virtual conference. Today's discussion on programs and practices addressing social determinants of health and healthcare access is important as our nation continues its dialogue on how to improve its healthcare systems. A prominent health official once said, "Public health is a powerful tool to level the playing field, to bend the arc of our country away from distrust and disparities and towards equity and justice." And so today we continue that conversation and highlight policy implications. Now, I'm honored to introduce to you Dr. Dina Refki, the Executive Director of the Institute on Immigrant Integration, Research, and Policy, a thought leader, an agent for change, and an academic powerhouse. Dr. Refki.
Guillermo, thank you so much for the introduction and for laying the groundwork very eloquently for this important discussion. Good morning, everyone, and welcome again to the webinar on social determinants of health. We're thrilled you are joining us. There's a wide consensus probably in our communities that the traditional paradigm of healthcare delivery has changed. We have come to the realization that vulnerable populations, including immigrants, face a range of non-health related conditions and needs that affect their health outcome. And in order for us to improve these health outcomes, we must address these conditions. So the messages that we aim to send with this webinars are as follows. First, that all patients need to be treated holistically by addressing both health and non-health related conditions and needs that affect their health outcomes. Second, we cannot treat healthcare as a separate system that is divorced from the wider context, which shape health outcomes. There's a need to integrate healthcare with human and social services in order to address the forces that adversely affect healthcare outcomes and that are non-medical in nature. Third, there are model programs and practices that effectively address these social determinants of health, and we need to offer them at scale. And we need to offer them in a sustained and consistent manner in order to achieve the mission of improving health outcomes. The Institute on Immigrant Integration, Research, and Policy commissioned a study on promising interventions that address social determinants of health facing immigrants. The team from Lehman College is here and will share their findings with you. But first, we will hear from our keynote speaker, Choi. Steve certainly does not need an introduction for those of us who have been working for a while in this field. His bio has been shared with all of you. Steve will speak about the work that has been done and is ongoing to advance immigrant well-being and immigrants' health in New York State. Steve will discuss the past and the current efforts to provide healthcare access to New York's growing immigrant communities, the challenges that we all face in improving health outcomes for this population, and the policies that would be most effective. Steve, please take it away.
Great, thank you. Good morning, everybody. I'm very excited to talk to you all and to have a conversation. And first, I wanted to thank Dr. Refki for inviting me to speak. I also want to thank Guillermo, the Deputy Director, and the Rockefeller Institute. And I'm excited to hear from some of the other panelists and the participants as well. And as I was thinking about what I wanted to speak about today, I actually wanted to take a little bit of a broader view, to kind of take the lens back a little bit and to think about something I've been thinking about a long time. And that is around the dignity and respect of human beings and of immigrant New Yorkers, and how that is so central to the work that we are talking about, and also how big of an issue that will be as we think about particularly the new wave of asylum seekers that's come to New York. So when I think about the social determinants of health and healthcare access, I think back to my time working not only at the Immigration Coalition, but before that as an immigration lawyer at the Asian American Legal Defense Fund and running a small grassroots community organization. And I was realizing that one through line throughout that time was that as immigrant advocates, as immigration advocates, so much of what we sought was dignity, was respect for immigrants as human beings and New Yorkers. Now, to be clear, much of what we fought for, particularly at the Immigration Coalition, was about the importance of day-to-day bread and butter issues that actually very directly impact the physical and mental health of immigrant communities. You know, we fought for greater access of undocumented students for tuition equity so that they could go to higher education and, and achieve a different level of success and prosperity. And we eventually were able to win the DREAM Act after many years of hard-fought battles. We also successfully won major victories around language access, ensuring that government agencies and benefits were accessible to limited English proficient immigrants, who could then access everything from healthcare-related services to business licenses to food stamps, and they would be able to do so through interpreters and translated documents. We also won for the first time state funds for immigration legal services, which is such a key factor in ensuring that immigrant New Yorkers can stay here, can be with their families, and be able to access the kind of supports for both mental and physical healthcare. And that was really critical. And that was one of the biggest political fights of my life. 7 years ago, Governor Cuomo announced with great fanfare that he was creating the Liberty Defense Fund. But oops, he actually decided not to put any zero state dollars. He didn't put any state dollars to actually support this Liberty Defense Fund. So it was all just a PR move. So we went to war with him, and we eventually ended up with $10 million in state-funded legal services. And this is something that Guillermo probably remembers very well. And I say this because we've come so far. And now the NYIC is fighting for $100 million in state-funded legal services, not just for the Liberty Defense Project, for the Access to Representation Act and other legal services. And they're actually fighting for the right to a free lawyer for every single low-income immigrant New Yorker who needs one. And I'm cautiously optimistic that in about a week, we'll see a historic investment by the state. And I say this because we've made so much progress in terms of fighting for these kinds of bread and butter day-to-day services for immigrants that have such a direct impact on the mental and physical health for immigrant New Yorkers. And I think that immigrant access to healthcare is really the next big barrier that we are fighting to overcome in terms of these day-to-day needs. The Immigration Coalition has been working with a lot of other partners on the Coverage for All campaign. And this campaign has been going on for years now, pushing for a state-funded essential plan that would include about 50,000 of the 150,000 uninsured low-income immigrant New Yorkers who don't have access to healthcare right now because of immigration status. Advocates came close last year. They weren't able to win a total victory, but honestly, when I look at some of the progress that we have made, I think it's more of an eventuality that we will achieve this in time. I'm cautiously optimistic that we will get there to the point where undocumented immigrant New Yorkers, and really all immigrant New Yorkers, are going to have access to this kind of state-funded basic healthcare services that's going to make a really big difference in terms of the physical and mental health of immigrant New Yorkers. And we've made great progress and won some great victories around these kinds of bread and butter kinds of issues that have this kind of direct impact. But that's not all that we fought for. And when I think about it, when I think about our time at the NYIC, we also fought for more symbolic steps that didn't give people a free immigration lawyer or cheaper tuition, but allowed them to have dignity as human beings. We fought to create a municipal ID document for New York City, which allowed all undocumented New Yorkers to get a government-issued ID NYC, that they could show with pride. Now, of course, it saves people money, provides discounts to museums and whatnot. But when it happened under Mayor de Blasio, it's also something that undocumented immigrant New Yorkers, New York City residents, could hold up and say, I belong just as much as everyone else. And our biggest fight was actually around driver's licenses. And as you probably know, in the wake of 9/11, in an atmosphere of fear and mistrust, Governor Pataki revoked the ability of undocumented New Yorkers to get driver's licenses in New York, stripping away a right for hundreds of thousands of immigrant New Yorkers. And as you also probably know, Governor Spitzer tried to make this happen unilaterally in 2007 because he was a bulldozer. And when he tried to make this essentially by fiat, by executive order, he faced a firestorm of criticism, not just from Republicans, but from Democrats. There's one county clerk in Erie County who said, any quote unquote illegal immigrant who tries to get a license from me is going straight to ICE. And her name was Kathy Hochul. And there was a Democratic congresswoman who sent out mailers opposing Spitzer and opposing giving driver's licenses to undocumented immigrants. Her name was Kirsten Gillibrand. And I consider it part of my job to never let people forget this part of our history, and much to the dismay of some of these elected officials that I just named. And so our biggest fight was for driver's licenses. And it was not just because it gave the ability for undocumented immigrant New Yorkers to go to work or to take their kids to the hospital or to go to houses of worship. But honestly, it was our biggest fight because of this kind of political controversy around these. The statement that you couldn't go that far around immigration in New York, that you couldn't give things like driver's licenses because of the symbolic nature of these licenses. And so when we fought for driver's licenses, it was because being able to give these driver's licenses to undocumented immigrants across New York State, from Staten Island all the way up to Schenectady, it was an unmistakable sign that, yes, immigrants were here to stay, that they were just as much a New Yorker and officially blessed by the state of New York. They were New Yorkers through and through, just like anybody else. And so this was really an example of a victory that was honestly less about saving people money or giving people access to some kind of services, but it was more about letting them stand tall with dignity and affirmation as human beings and as New Yorkers. And so I'm greatly concerned with what I see today in New York State, because what I see today is a real erosion of that ideal. And I'm deeply concerned about the potential future impacts on the physical and mental health of immigrant New Yorkers, particularly the newest arrivals who have really come in this wave of asylum seekers in the past year or so. You know, as we all know, you can't escape this. Somewhere north of 150,000 new immigrants, really from around the world, have come to New York State in this past year. And from a dollars and cents perspective, New York City and New York State have stepped up, opening up dozens of new shelters, making legal services available, providing food and housing and emergency medical care. And the quality of this is obviously a great concern. And there's legitimately a lot of real questions about this. But there's no doubt, I want to be clear, there's no doubt that both the city and state have made significant investments in supporting these new immigrants. In fact, when the state budget gets finalized any day now, there's going to be what's estimated to be probably north of $2 billion invested in this next fiscal year to support these new immigrants. But I'm concerned less about the dollars and cents aspect, and I'm more concerned about the rhetoric and the atmosphere that has arisen. You know, of course, Mayor Adams' comments have been a significant factor. His talk about the arrival of these asylum seekers potentially destroying New York City, talking about these asylum seekers as a burden, focusing on the downside, the costs, the burdens that he thinks that New York City is facing. You know, making comparisons and talking about us versus them, blaming potential service cuts on them, meaning these, you know, migrant New Yorkers affecting us as real New Yorkers. This kind of rhetoric is just so destructive and corrosive to the kind of ideal and corrosive to the dignity of these New Yorkers. And his ill-fated effort to bus asylum seekers to upstate areas without doing the kind of due diligence and on-the-ground organizing that you really need has also sparked a huge wave of really cheap political point scoring by Republicans who are only too eager to fan the flames of resentment and hatred. You know, they're talking about the crime and disease and homelessness that these asylum seekers might bring, all of which are completely unfounded. But the fact is that we are left with the spectacle of 150,000 new immigrant New Yorkers who have risked everything to come here and are the recipients of, I'm going to be frank, you know, some generous benefits, but are unable to work and are treated and viewed with great suspicion and are thought by so many New Yorkers as undesirable burdens because of the rhetoric of so many of our elected officials. And you talk to these new immigrants, you hear what they say, and it is crystal clear that they do not feel a sense of dignity and respect as human beings trying to make a better life for themselves and their families, but instead they face despair and worry that they can ever be seen as human beings and New Yorkers. And so I am greatly concerned with the long-term health impacts, both mental and physical, of this loss of dignity for these newcomers and the hatred and the vitriol that I see being directed against them. The fact is that these folks are here to stay. They're going to be key members of our society. And how we support them with direct services and education and jobs and legal services, of course, this is important. But the rhetoric and the narratives that we use as a state and as a city when talking about them is perhaps just as important, if not more so. And that is why I've helped to start the Ellis Island Initiative to try to lift up local native-born residents who can welcome these new immigrants and together try to change the narrative from one of burdens and costs instead of that to one of opportunity and growth. And so we have a long road ahead. There's so much to do. And I think we would do well to fight not just for the bread and butter services for New Yorkers that are so critical, for things like coverage for all and these kind of campaigns to provide direct physical and mental health services. But also, I think it's so critical to make sure that we are also fighting to restore the dignity, respect, and humanity of these newest New Yorkers that is under attack right now. I think the kind of impacts that we're going to see around these narratives and our ability to fight back is going to do so much to shape our ability to have impact, not just on this wave of the 150,000 newest New Yorkers, but on the 4 million immigrants that call New York State home. This is really the battle, I think, that we need to be fighting for the years to come. So thank you. Thank you for all the amazing work that you are doing and the attention that you're bringing to this vital topic. And with that, I'll turn it back to the Rockefeller Institute folks.
Thank you so much, Stephen. This really is a wonderful insight and a wonderful presentation and wonderful thoughts that you shared with us. Thank you for making us hold on to the idea that all human beings deserve respect and deserve dignity, and giving us the hope and the optimism that there's light at the end of the tunnel, but also reminding us that this is a perennial struggle, that we really need to pay attention to the work that still needs to be done in changing the mindsets and looking at immigrants from an asset lens and not from a deficit lens. And so thank you, and we'll bring you back to the roundtable discussion after Nicole and Amanda's presentation, our Lehman College team, who will present their findings of a synthesis they conducted to identify promising interventions to address social determinants of health. Amanda and Nicole, take it away.
Thank you, Dr. Refki, Mr. Martinez. And we're going to talk to you today about the importance of interrupting the social determinants of health for foreign-born New Yorkers. I'm happy to be here with my colleague, Dr. Amanda Sisselman-Borgia, and to Mr. Choi's point earlier, one of our professional values as social workers is actually dignity and worth of a person. So I think that transitions nicely into what we're going to talk to you about this morning. So we're going to just give a general overview of the social determinants of health, define them, contextualize them, and talk about them in relation to foreign-born New Yorkers. The most common social determinants of health that we found. We're going to discuss interventions that can interrupt these social determinants of health and interventions more broadly, highlighting some specific social determinants of health and policy implications. Next slide, please. So just to give a little overview, the term social determinants of health has been known or referred to as the social determinants of health inequities or simply health inequities. However, the two concepts are distinct. So, the World Health Organization in 2008 said that social determinants of health are the conditions or environments in which people are born, grow, live, die, work, age, and play. And health inequities have three distinguishing features. When combined, they are systematic, socially produced, and unfair. And if you note, the authors, Dahlgren and Whitehead, stated that because they're socially produced, they can also be modified or addressed. Next slide, please. So this visual, we think is a good way to kind of show how the social determinants of health impact a person's health and well-being. And so 20% of a person's health and well-being is related to their access to care and the quality of services being provided. Additionally, the physical environment, social determinants, and behavioral factors drive 80% of health outcomes. And this compelling evidence documents these strong associations between socioeconomic risk factors and health outcomes. And therefore, we need to address these social needs and provide social care. Thank you. Next slide. This is a helpful visual just to see. On the left, you have when health inequities are high and community assets are low, health outcomes are at their worst. So you have the dying tree or the tree with no leaves, and you can see that environment is rife for inequities and outcomes that are not advantageous to anyone in the community. And on the right, you'll see that when inequities are low and community assets are high, health outcomes are at their best and allows people to flourish and to hopefully live healthy and productive lives. Next slide, please. So this figure is taken from a conceptual framework for action on the social determinants of health. It was from the Commission on the Social Determinants of Health, and it was written by the World Health Organization. And it outlines the structural determinants, define social class divisions. Social class divisions determine the distribution, power, prestige, and access to resources. And the arrows between social divisions and the socioeconomic political context are bidirectional. The most important social stratifiers per the Commission on the Social Determinants of Health are income, education, occupation, social class, gender, and race and ethnicity. And this model explains the formation of the social determinants of health inequities and the role of social determinants of health in that process. Thank you. Next slide. So, foreign-born individuals often face unique challenges and barriers to accessing healthcare compared to non-immigrant populations. Ensuring that their basic needs are met should be a priority and is essential in promoting human rights and has implications for public health outcomes. So you can see here that immigration status intersects with various social, economic, and environmental factors that impact healthcare. And you can also see that healthcare utilization relates to access, which is one of the most common social determinants of health that we found. And all of these together, income, language and cultural barriers, housing insecurity, food insecurity and nutrition, immigration status, and legal barriers, as Mr. Choi mentioned as well, and access to healthcare are themselves social determinants of health for foreign-born New Yorkers and immigrant populations. Thank you. Next slide. So we thought it was important to specifically mention, in light of the political environment and comments that actually Mr. Choi alluded to as well, that stigma and discrimination are often associated with immigration and for English language learners as well. And this intersects with other identities and can lead to significant discrimination experiences and can diminish access to healthcare or desire to seek out healthcare or to receive healthcare opportunities that are not tailored to the specific needs of those individuals, like addressing their culture and language. Next slide, please. Thank you. So on this slide, you can see some additional social determinants of health that we found and some interventions that are in the literature. And so, you know, we're going to say a little bit more about these, but focusing on immigrants' health, it's not about prioritizing one group over another, but rather recognizing and addressing the unique needs and vulnerabilities of immigrant communities to ensure health equity and promote the well-being of all individuals within society. So in essence, prioritizing immigrants' health is a matter of promoting equity, fulfilling human rights, and advancing public health for the goals and benefits of society. But there are concrete things that we can do, and we need to allocate resources to be able to scale these up, right? So there's a lot of good work being done in pockets across the state, and how can we scale these up to ensure that this is happening systematically. Next slide. And now my colleague, Dr. Sisselman-Borgia, is going to take the next slides.
Hi, thank you for having us. I think Nicole just left off with an important slide about the interventions that we found in New York State, across the state, that were being done to specifically address health among immigrant populations here. I'm going to talk more broadly about interrupting social determinants of health, including interventions that are being done nationally and some internationally, so that we can see more about what we should be doing to scale here in New York State and more broadly. They fall into several different categories. We're going to talk about health literacy and language in promoting healthy behaviors. We saw many interventions looking at screening, followed by referrals to different organizations, finding patients in hospital systems and understanding more about their needs in order to make referrals. And we saw many interventions that were designed to provide more culturally responsive treatment. More broadly, I'm going to talk a little bit about education. I'm going to talk about youth and parenting, interventions designed to address violence in the community, HIV prevention, and I will also talk a little bit about community health workers as an intervention. So as professors in an institution of higher education, specifically in the Bronx, where many of our students are from immigrant populations, we felt it very important to talk about education as one of the known interventions to improve health and well-being among immigrant communities, among everyone. For that matter, we know that education improves social and economic mobility. We've seen that in many studies. We know that it improves access to jobs and health insurance through employment. So not only are we increasing income, not only are we improving professionalism, we are also improving access to health insurance. The health professions are a growing field. Providing access to higher education in these fields will not only provide access to jobs and health insurance, but it will also shift the landscape of the health workforce into a more culturally responsive group of individuals who will ultimately change the way the healthcare system is delivered, we hope. So we want to make sure that we understand the need for more representation from immigrant communities within the healthcare professions to solve some of the issues that we've been discussing and to solve some of those problems that Mr. Choi brought up in the beginning of his talk. We also saw many interventions that were designed to address youth and parenting. There are effective interventions out there that address communication patterns within families. It's important to help children adjust to their new environment and surroundings and to help parents help their children adjust. As we talked about, immigration itself is a social determinant of health because of the experience. Some of the experiences prior to and during the journey, as many of my students call it, can be traumatic and difficult, even under the best of circumstances, leaving family and friends behind, coming to an entirely new community. These are difficult things for people to navigate. So we've seen some effective interventions that look at communication patterns within families and help them sort of learn how to talk to their children about these experiences and not sweep them under the rug, as I think as human beings, sometimes we do that, right? We sweep things under the rug. Breastfeeding interventions were something else that we found when we did our synthesis of the literature. There are communities across the state, hospital systems across the state that are working to improve knowledge about breastfeeding and provide information in different languages and programs that are designed for women and families in Spanish, Korean, and Chinese to help people navigate breastfeeding after giving birth and to make sure people understand the importance and the health benefits involved with breastfeeding and to help deal with this very difficult, some people find it difficult experience following birth. We also found school-based programs that address trauma in children who have recently immigrated. Those are very effective. Also, school-based health centers often provide specific programs for children. We also found various mental health interventions that address this specifically in children, as all kinds of change can be traumatic for children, but specifically things that happen in their journeys coming here to the States. As we talk more about the migration experience, violence and trauma related to that, we saw school and community-based interventions addressing this. Intimate partner violence is also something that we saw interventions designed to address specifically for Latina moms. and providing legal assistance. When we talked about when Nicole had that slide up about legal assistance, free legal assistance, that covers not only immigration related legal concerns, but also concerns related to intimate partner violence, which happens, and it happens here, it happens everywhere, and that doesn't go away when someone comes here to the States. It's still here. So we need to be able to provide free legal assistance for women in those circumstances, and those free legal clinics have been effective. These interventions, they promote family cohesion, they help women to become empowered and to feel more comfortable seeking help and expressing their needs related to their relationship problems. And it also destigmatizes mental health issues. We want to make sure that people do not feel so stigmatized when they look for seeking help. Different cultures have different understandings about mental health treatment, and there's a lot of stigma and feeling about seeking help for this, and we need to normalize that. And interventions that destigmatize mental health and make it more universal in schools and in communities are effective, because people then seek the care. If they are universally screened or universally applied to all children, then it's less stigmatizing for those that really need it. Shifting gears a little bit now, we saw interventions that aim to address HIV prevention. Nicole and I are heavily involved in some programs now to reduce inequities in HIV infection, because the rates are so high among young people in particular. So we saw effective interventions that used videos in the Spanish language to inform people about HIV and how to protect themselves, where to get tested. Offering direct testing opportunities to migrant workers wherever they were was very effective. Teaching them about how to get condoms and how to use them properly was also effective. And we also saw the church-based interventions offered higher rates of testing and reductions in stigma, like I just mentioned. Reducing stigma and finding ways to make these interventions more universally available is very important. Community health workers, very much related to all those church interventions. Many successful interventions are built using this model, including HIV prevention, breastfeeding, chronic disease management, diabetes, cardiovascular health. This looks like people actually within and of the community talking to people within the community, right? These are some of the most important interventions I think that we can put out there. I think that, our current healthcare system is not necessarily serving people the way that we want to. And I think Mr. Choi made that point very clearly. So we have to think about alternative ways to make sure that people get information and use the information. And people from the community are often trusted differently than people within the healthcare system. So while we are in this process of educating people and turning over the workforce to be more culturally responsive, it is important to also include these community health workers. And I think our newer systems are going to include more community health workers to make sure people are connected to care and they know where to find it. They're going to listen to knowledge from people that they trust differently from people that are outside their own communities and environments. So this is very effective based on that trust alone. And it also provides jobs and connection to health insurance for people in the community as well. I mean, we're not only talking about connecting people in the community to services, but also the people that are the workers. They gain a sense of self-efficacy. They gain professionalism and access to social mobility through their own work in these programs. So, there are some implications here. There are many effective interventions happening in the state, including community health workers that aren't necessarily documented. We know they're effective, right? The literature tells us that this is an effective intervention, but we don't know where all these things are happening all over the state. So we need to find more of those interventions, right? And we need to be able to document them more clearly in the literature so people can find them. We need to address stigma and provide interventions within cultural contexts and make sure that our interventions are culturally responsive. So training people in that way is very important. Education is a big one and an important one. Funding for people in immigrant communities to train to become health professionals, I think, is one of the most important things we can do to start shifting the actual workforce, right? Like, unless we shift the workforce, unless we shift who's out there doing this work, we're going to have a very difficult time making real sustainable change. There are federal initiatives that provide stipends. Nicole and I have led federally funded grants to provide stipends to our students to motivate them to complete school, to provide them funding so that they can take time off from work. These should be more inclusive of immigrant communities. There are requirements in these federal programs that if you don't have citizenship or you don't have all of your legal paperwork dotted and crossed, you are not eligible for these programs. We need to make these programs more available to immigrant communities, and we need to encourage New York State to match funds that federal initiatives have in order to provide these opportunities for people, because they will ultimately contribute to our society, they will contribute to our economy, and they will change the way things look today. So I think that's very important. Funding for statewide evaluations of evidence-based programs that employ community health workers is important. We need to find all the programs that are out there, right, that are in different pockets. There are so many grassroots organizations out there doing amazing work, and we just don't know where they all are. So we need to do more surveying and, provide funding to find out exactly where this evidence base is. We should have licensing requirements for current health professionals and organizations that address cultural competence and cultural responsiveness, right? People should be required to train, and they should be required to do that in order to keep their licenses. School-based services, right? These need to be integrated with our community efforts. Schools and communities need to be much more connected. Community health workers should be in schools. Schools should be very much connected to the healthcare system. This is where people are. We talk about meeting people where they are in social work, and I think meeting people where they are is really, really important. And many people show up to schools to bring their kids, so you'll find them there. In terms of policy implications, sanctuary states and cities are very important. I think we probably all know that, but we wanted to really emphasize how important that is, that people feel safe and they know where they can go to get what they need. Like I said before, we need to do a better surveying of interventions to find out where these grassroots things are happening. Nicole and I spoke to several informants that were in the community and telling us about all these amazing things that were happening, but there's no documentation of them. So we want people to be able to find them and do them and replicate them, right? So we want to kind of find all these things all over the state. And I think we should be building on faith-based communities. We think that including faith leaders in policy discussions and funding related conversations is very important because, again, people show up here, right? If you're looking for people and how to impact people the most, schools and faith communities are two of the most, the biggest communities that we can connect with in order to have impact and get access to people. So I will stop sharing our screen and offer the opportunity for questions and answers. Thank you.
Thank you so much. Dr. St. Louis and Dr. Sisselman-Borgia. We'd like to open it up to participants right now. This is excellent work. You've done so much research that really identified several of these interventions that we think are important to address the social determinants of health. Participants, please use the chat function to communicate any questions, reactions, comments, or reflections. Since this is a webinar format, this is the only way, unfortunately, we can interact with all of you. And we will address as many comments as we can. So let's bring in Stephen Choi to the roundtable. and officially start the discussion segment of this webinar. And I will throw out the first question, if I may. So we talked a lot about community-based or place-based initiatives. We talked about policy interventions. Let's talk about what the healthcare system needs to do within healthcare institutions at the meso organizational level. And we know one of the determinants of health is the healthcare system itself. Compliance with the federally mandated culturally and linguistically appropriate standards, what we know as CLAS, is a huge challenge. We know that from work that we have done during the pandemic and after the pandemic, and providers were telling us that the CLAS system was, before the pandemic, was incredibly fragile. And during the pandemic and under the weight of the crisis and the pressures that healthcare workers were facing, and understandably so, that system completely disintegrated. And so we also conducted work with providers who were telling us that language assistance now, after the pandemic, is not provided in a consistent manner across departments within the one healthcare facility. And there are a lot of violations of the CLAS standard, the culturally and linguistically appropriate standards. So these are federally mandated. And so also there is a lack of knowledge, a lack of information about CLAS. Many assume that CLAS is just about providing language assistance through most often using the telephone interpretation. And that is the extent of the obligation they feel to the limited English proficient patients. So we know that CLAS is not just about language assistance. It's about instituting transformation within the system of care so that the institution has responsive governance, responsive leadership, workforce, and Amanda and Nicole, you alluded to that by referring to the training and the recruitment of people from the immigrant communities so that they are representative of the population that they serve. It's about also instituting mechanism of continuous engagement and accountability. So the question is, how do we address this gap that exists in compliance with CLAS and other state level policies and mandates that require healthcare facilities to address the issues compliance with these mandates? Any thoughts that you can provide?
Sure. Thank you, Dr. Refki, for that question. I think there's a critical need for interventions at the healthcare organizational level to ensure that the systems themselves are more responsive, and that would include cultural responsive training for all healthcare staff. And it should go beyond just the mere awareness of cultural differences and should focus on practical strategies for delivering culturally responsive care. Also leadership and governance, right? We want to cultivate strong leadership commitment to cultural responsiveness and CLAS at all levels of the organization, and prioritize and allocate resources for culturally responsive initiatives, hold staff members accountable, foster a culture of inclusivity and diversity, and then also community engagement and partnerships. Establishing partnerships with community organizations and leaders, train community members and peer educators, the community health workers. The healthcare system as it is designed is not meeting the needs of people in many communities. And therefore, community health workers are actually shifting the nature of healthcare systems and changing the dynamics of how people learn about health problems and solutions and how they can find and access healthcare. Also tailored programs and services that address specific cultural and linguistic barriers to care. And you mentioned translation and as a former hospital social worker, we had those translation phones, but nobody ever trained us on how to use them. So, for instance, instead of talking to the translator, you're supposed to talk to the person that is being cared for or providing the service user, right? And so, these are really important conversations, but what we found works best is, to have staff members that speak the languages of the individuals that are receiving care. And, it also then takes away the burden from family members, specifically children, in doing that. And, there's also diverse workforce recruitment and retention that you mentioned. And then I think there also needs to be continuous quality improvement, implementing mechanisms for ongoing assessment and feedback, regular audits, patient satisfaction surveys, quality improvement initiatives, focusing on addressing identified gaps and barriers.
Thank you, Dr. St. Louis. Dr. Sisselman or Mr. Choi, any input on this question?
The only thing I would add is that I think it's so important to provide language services because of the burden that it often places on children. And I think Nicole alluded to this, but I think children are often pushed to translate for their parents. And this can be really stressful, especially if it's around issues that are uncomfortable or, they don't want to address that with their parents. I think it's really important that we kind of take this burden off of them, because that can add to stress and trauma around health issues with their parents if they're too young to sort of take that in and digest it.
And of course, we know that even using untrained medical interpreters is against class, is against the culturally linguistically appropriate standards. But often, and that comes from our research of one particular healthcare facilities where we heard that, it's a regular practice. And also the innocent bystander, where they announce on the microphone that we need someone who knows Spanish or speaks this language, and anybody who speaks the language would come in and intervene, which is against class and against the policies and mandates, because you need trained medical interpreters and not the innocent bystander. Mr. Choi, any addition to?
This is actually a very fascinating conversation. I have not been as knowledgeable, but language access is something that I've worked on for quite a while. I mean, and I worked a lot on it in different kinds of contexts, particularly in terms of workers and working with the State Department of Labor, working with the Workers' Compensation Board to increase language access. I think the good thing is that there's much more attention being paid to this issue. There actually is a new state office of language access that has been created in the last several years. I helped to sort of plan out a listening tour for the state office of language access around the state to kind of announce the services and the opportunities that they have available. And what I would say is I think that is a new resource, and I know that the staff there are very interested in, because this is what they focus on. And I feel like, to one of the questions in the chat, I do think that they are ready and willing to really think about how to engage with healthcare providers and community organizations. And I think that there is a lot of resources that they potentially could bring to the table. So that's just one thing I would encourage in thinking about the State Office of Language Access and some of the resources that they're really bringing to bear, particularly in the healthcare context, because I don't think that they have really been thinking about that, but is certainly a very ripe and fertile area for potential partnership. So that's the only thing that I would say.
Right. And speaking of partnerships, we have a question in the chat about particularly the initiatives that exist, partnerships between healthcare facilities and the community organizations and government agencies? Are there promising models of collaboration? And what are the gaps or barriers? Anybody want to take on that question?
So some of the, I was just writing this in the chat, some of the collaborations that we looked at in terms of community health workers, these were, some were collaborative between healthcare systems and community-based organizations. I think there's some, New York Presbyterian, I think is a good example. They work with some of the community-based organizations to train and implement community health worker interventions throughout the community. Some of the health systems train and send the community health workers out from their own systems. But there are some that are collaborations between community-based organizations and healthcare systems. It's difficult, I think, to get those things going because of the different systems. Community-based organizations and healthcare systems both have different ways of operating. So I think it becomes complicated in that way, but there are some out there. We need to find ways to make those collaborations easier and to make systems merge differently than they do right now, because I think those barriers, the systemic things, like the way that one budget office works at one organization versus the other organization, these are the things that sort of like make that difficult. Not necessarily the people involved. I think it's mainly just like those systemic issues.
And of course, we've seen lately many funding innovations, and including of Medicaid as sources of funding for some social determinants of health. We've seen the Department of Health really doing a lot of great stuff along these lines. Yet some observers expressed concerns about the use of this particular funding stream for supporting non-medical needs. Of course, if we think that the health and social care service systems ought to be integrated and work hand in hand, then the use of Medicaid is really a logical measure. But some people are saying that this really overtaxed the system. I'm interested to know what are your perspectives on that, and what alternatives exist to provide sustainable and robust sources of support for communities to address social determinants of health. Well, we know there are incredibly wonderful models there. One of the issues that we see is sustainability and consistency. And Medicaid seems to be the answer to that. But what do you say to people who are saying Medicaid is not the way to go?
So, Medicaid can play a really valuable role, I think, especially in supporting social determinants of health. But it should be part of a broader strategy that includes preventive interventions and community-driven approaches. With that said, there should also be diversifying of funding sources for social determinant of health initiatives, like leveraging public-private partnerships, philanthropic contributions, community development funds, and other sources of funding to contribute to comprehensive and sustainable interventions. And, I think prioritizing equity and community engagement in that is also very important. And I would just say we really need to invest in preventive and upstream interventions that can help mitigate the need for costly healthcare services downstream, right? So we can improve the overall population health outcomes and reduce the burden on healthcare systems if we address housing instability, if we address food insecurity, if we address education access and health access and economic inequality. So those are really important.
So Steve or Amanda, any input on that? So Nicole thinks really the diversity of funding is crucial here. Obviously, we need that consistency. We need that sustainability. And community development funding seems to be also a really important avenue there. Okay, so let's move on to another question that we have here. Are there agencies out there to help students who graduate with a college degree but still don't or can't get a Social Security number in order to work? Any ideas for Catherine on this question?
I would just say that I think that there's a lot more attention being paid to this now than there has been. You know, I think especially with the wave of asylum seekers coming to New York State, who are not able to work, they're not work authorized. Some of them may be in the process of getting that work authorization, but I think, you know, I've heard estimates from 30 to 40% of the new arrivals who are part of this wave of asylum seekers are never going to be able to be work authorized. They're just not going to be eligible, or maybe temporarily able to. And regardless, I think so many of them, even if they applied today, it would take months for them to actually be work authorized. And so I do think that this is an issue that, particularly on the state level, people are paying more attention to. Because what I think that, you know, you have these optics where folks want to work, are not able to work, and they essentially become sitting ducks and targets for people who are going to take, you know, like the New York Post are going to take pot shots at them. So I think one thing that I would flag is that, you know, a lot of folks on the workforce development side and on the jobs training side are really thinking about how can we enroll folks who might not necessarily be able to work, but be able to actually be part of workforce development programs that do not require that. So federally funded, my understanding, and I'm not an expert in this, is that federally funded programs, you're not going to be able to open them up. But state funded or locally funded or privately funded entities, you are not only able to enroll folks who are not work authorized or don't have Social Security numbers, you're not only able to enroll them, there's also a potential possibility of paying folks stipends. And I know that some entities like 1199 are actually thinking about taking that step where they're going to say, we're going to enroll folks. And so as they're waiting for their work authorization to potentially come in, they're getting trained for entry-level healthcare jobs or nursing jobs or whatever, and they're getting paid a stipend so that when their work authorization comes in, they can immediately jump into the workforce and be able to do that and not use that to be the start of their journey. So I do think that there are more, there is a lot more attention being paid to what can be done to enroll folks, to help train them, to provide the kind of skills development, especially in the healthcare field, before they actually have their work authorization. And it's one of the things that we're pushing the state to really kind of see if they can scale.
Yeah, and Stephen, that brings up a really good point that many states are now really stepping up to the plate and doing what, trying to fill the gaps where the federal government's inaction has been a really detriment to communities at the local level. Amanda and Nicole, any responses to this question? All right, so we'll move to another question about cultural competency trainings. Initiative offered to workers, schools, and organizations to acquire cultural competency. And I had also a question related to that when we talk about cultural humility and acquiring. really that knowledge and experience and training, which also came up in rather in our research many times, the lack of providers, cultural competency, the knowledge and experience and training in serving this population. They tend to lump all population in one and treat them as such, and a lot of stereotypes that really are harmful. And when we talk about cultural training, not all trainings are the same. And was wondering if there is an evidence-based training that you encountered in your research, Amanda and Nicole, that can be institutionalized and standardized across the board to address provider-related challenges. We know that cultural humility is really a journey, right? And not a destination. It's something you work on throughout your life, and we're never really fully there yet. So are there interventions that are evidence-based? And Marian Nelson here asks, what initiatives are offered that you encountered that perhaps are evidence-based or not? What does the landscape look like? Because we all talk about cultural competency trainings, but they're not all equal, right?
So this is very tricky because there are interventions out there, right? And not many of them have consistent findings and results, because as you said, everyone's journey in this area is unique and everybody has their own process for dealing with understanding and humility and all of that. So one of the things that Nicole and I have been working on is testing a virtual reality training for people who, for students to understand more about things like homelessness, about racism, discrimination, to provide a safe way for people to sort of like understand what it feels like to sit in a situation and feel uncomfortable, and then to have an opportunity to debrief and discuss. And our initial findings are showing it's very powerful and effective. That we're only in the piloting stages here, so but so far it seems like it might be something promising. I think, we talked about institutional messaging being very important. Like when organizations put forth kind of like, this is how we're doing things, you start weeding people out, but that takes a lot of gumption. It takes a lot of, sort of being able to push back against long existing systems, and it's hard. But these are the kinds of things that are effective in that constant quality improvement thing, constantly checking in, member checking, all of that. These are the kinds of things that are effective when they're implemented properly. I don't know, Nicole, do you want to add?
Sure. So, I mean, I think it's important, but it's also difficult work, and it really needs to address interpersonal isms, right? Like racism that occurs between individuals, and then institutional, racism and discrimination, which is expressed through social and political institutions, and then internalized, discrimination and racism, those beliefs that individuals hold within themselves, against themselves. And I think there also has to be an element of healing, right? Like there has to be an element of addressing that. And we've undertaken some of this work in our department, and it is work that is ongoing. It's not just like a one and done, 2-hour diversity and inclusion seminar. It's work that has to be done at multiple levels simultaneously.
And we have a question. Thank you, Amanda and Nicole. We have a question here in the question box. How do you disrupt the nonprofit complex of structural racism and oppression in marginalized communities while getting your work funded? Many organizations are part of the problem of maintaining the status quo. And it's a large, of course, statement there. I don't know if any of you want to answer or respond to that. So
I can go quickly. I think that this is really, really hard, right? I mean, so you have to say the right thing to get funded, right? So we have to kind of like figure out how to get the funding. And then once we're funded, we have to talk with funders. Once we're in there and we have funding, then we have to work on disrupting, right? Then as a funded organization or individual, we have to go to the program officers and say, okay, the way you're asking these questions is not appropriate, right? The way you're collecting data on our students' race and ethnicity does not feel good to them, right? And we have to change that. So, I mean, I think that it starts with figuring out how to get yourself into the system and get funded, and then kind of like becoming disruptors once you're in the system and making suggestions. And once you're funded, there are oftentimes more ways to get your point across and have program officers hear you and provide suggestions to them that can be implemented. I mean, I think we've had success in that way, whereas once we're funded, then we talk to the program officers and they're more sort of willing to hear what we say, and then they go back to the people that are above them.
Yeah, and Amanda, that also reminds me of a point that was made earlier, that really it's not enough to just provide the trainings of people in cultural humility, but you have to have accountability structures, right? And you have to implement those structures within performance measures and in performance evaluations, and have design the project in ways that where these accountabilities mechanisms are embedded. And so when you're writing the grant, think about that. How do you hold the organization and the staff accountable to maintaining standards, and not just leave it up to chance that they will comply with standards? But I don't know if Nicole or Steve want to chime in. Please feel free to do so. So another question that we have, are there funding sources that support work training programs for undocumented individuals? And we know that CUNY has Center for Undocumented Students that are really completely designed to serve those students. So I would look that up, but to our distinguished panelists, any other resources that you can provide? Stephen, are you saying something? You are muted.
Oh, yeah, sorry. I know that this is something that the city is thinking about a lot, particularly given what's happening with asylum seekers. Getting them to work is obviously a big focus, and they just had a meeting yesterday with the federal and state Department of Labor about being able to connect folks to good jobs. As I said before, I don't think that, I think that there have been legal questions about whether you could even enroll undocumented folks in workforce training programs, let alone be able to provide them with some support during that. And I think the answer is yes, you can, but it's taking a big shift in mindset to be able to do that. I mean, when I look at federally funded programs, you're not going to be able to do that. But from because like the federal funding is really, as far as I understand it, is tied to immigration status. But there's no reason why state dollars shouldn't be able to do that. And there's no reason why private institutions, foundations, or donors wouldn't be able to provide support for that either. So, and that is a point that we're trying to make to the state, we had a very illuminating conversation with the state, because we asked them, we said, what are you doing in terms of workforce development, job training? And the state's response is essentially, they need to get their work authorization. And we said, That's not going to work. Yeah, it's going to take months for people to get their work authorization. There are existing folks who are undocumented who are, like it doesn't make sense. And that, a bunch of folks are not going to be able to actually get their work authorization. So I do think, and if the state is spending $2 billion plus, there should be, like some of that should be going to that. And, so as long as it's not federally funded, as long as the source of this is not federal dollars, there is potential. And I do think that there's a mindset shift that we all have to be doing with the state and with localities as well, right? There's nothing that's stopping New York City from being able to do this either. As long as like I said, as long as the funding is not coming from federal funding streams, there should be no legal prohibition on doing that.
Right, right. And definitely I go back to what you said, Stephen, at the beginning, dignity and respect. And work is really integral to dignity and respect. And at the local level, we see them, we hear them, and integration really happens at the local level. And so localities and state should really step up and address those gaps that the federal government is and dismantle those barriers that the federal government puts up. So another question in the question box is about any collaborations between health providers and colleges to develop a medical interpretation workforce. So obviously, this is a very important area where we know we don't have enough medically interpreters who are trained as medical interpreters. Any insights you can provide about colleges and healthcare institutions and the provision of medical training, medical interpreter training? So I don't, and what I'm aware of, not the colleges in particular, although I cannot say for sure, there might be out there, but this is basically done through the nonprofit sector. There are nonprofit organizations that are providing the medical training across the state. So, but I'm not aware of of colleges that provide that and in collaboration with the healthcare organizations. So moving on to another question that we had for our panelists is about, Amanda and Nicole, you looked at these interventions, and if we asked you to really think about the elements that are in common of these successful interventions, what would these elements be? And so what comes to mind is really a very promising program that the New York State Department of Health is doing, which is called the New York Healthy Neighborhoods Program, that has been labeled as or hailed as a promising program because it addressed determinants of health. It is about unsafe housing, addressing housing safety and housing-related illnesses, injury, hazards induced by indoor air quality, lead, fire safety. So what happens is there are, the program targets these high-risk areas and do home visits to identify those hazards and then connect the families to an outreach worker that provides training and education and referral to reduce those hazards. So that is one of the promising programs that really address one particular social determinant of health and is done by the Department of Health, the New York State Department of Health. And so you can definitely identify elements there, but also you, Amanda and Nicole, looked at several interventions. What are the common elements that we have to keep in mind as we develop new programs that address social determinants of health and that we must embed in these programs?
Yeah, so I think some of the most common things that we came across, I mean, we're, kind of going to where people are, I think is one of the most effective ways, whether it go to the hospital bed where people show up, because people show up to hospitals, they show up to churches, they show up to schools, right? So going to where people are is probably going to be the most effective. Finding them in these most common areas is a way to engage people. I think that is the most effective way to find people and refer them. We together kind of like came to that conclusion through this work. I think although the New York State Healthy Neighborhoods Program does not specifically target immigrant communities, they target low-income communities, which immigrants often find themselves in when they first come here. And because of all the disparities and the inequities, they're kind of lumped into these categories. I think we need to tease out research-wise, data-wise, kind of like what the impact is on them specifically. Like, I think we think that the impact of going there, the home visits, the referrals, all of that is very important. And we think that that in itself is probably effective, but we need to do a better job teasing out which pieces of it are most effective for immigrant communities and what we can do to make them more effective and to amplify that the intervention effect for this particular community. They're separate and unique and have their own needs that may not be the same as people who are born here. So I think we have to do a better job in just sort of like teasing out that data. Nicole and I are also working with CUNY Cares, which is a new intervention through the CUNY Central office to provide basic needs to students at CUNY who might be homeless or food insecure. And on a project that I worked on, in the recent years, trauma associated with food insecurity, associated with poverty, associated with housing insecurity, all of this is very interconnected. So I think finding ways to address the mental health issues and the basic needs together, like this CUNY Cares initiative, is going to be very important. I think that, and that's again, one of those things where we're going to people where they are, like we're finding the students where they are on campus because they have to come for class, right? So it's involving faculty and engaging faculty and sort of saying, okay, well, these things are out there, let us know how we can connect you. So I think that's the biggest thing, is just kind of like finding people where they are and meeting them. Nicole, I don't know if you want to.
Sure. I also think that there needs to be, interdisciplinary approach and a multi-sector collaboration. So bringing, all the stakeholders together to coordinate efforts. These issues are too big for one discipline or one area to solve. So collaboration across social services, environmental health, housing, public health, coming together. So it takes an actual village, right, to solve this problem.
So thank you for that. I'd be remiss if I didn't ask you the question about data, because we are really talking about keeping track of outcomes. And we struggle as researchers to find data that is aggregated by foreign-born status, by language. And so what advice or recommendations do you have? We've heard in our research over and over that it's not enough to just, even the fact that the most common data that is collected is about race, but it doesn't really tell us about foreign-born status or even preferred language sometimes, and the needs of the communities that we are serving. Do you have any perspectives or recommendations that you want to put out there on how to standardize data collection, but what also data needs that we have in order to keep track of quality and outcome of programs, as well as really assess metrics of success as we talk about social determinants of health for this population and health outcomes?
I think, using participatory action-based approaches is going to be very important. I think having communication and conversations with faith leaders, with people at community-based organizations, and people at the government level is going to be crucial, because we're going to have to talk to everyone about what success looks like, right? And our own definition of success as academics may not be the same as people that are actually steeped in this in the community. So we have to find out like what it looks like first, and then we have to work together to create standardized tools to measure this, but also to look beyond the standardized tools and to be okay collecting qualitative data and understanding more about what these experiences look like for people. Yes, it may reduce trauma, or no, it may not, but what was that experience like for this particular woman, this family that went through this program, this intervention? I think we need to standardize it being okay to get that kind of information and to share it publicly. We also want to be careful not to overshare information, and, to allow participants to have the dignity and confidentiality without sharing their entire life stories. So, a couple of sentences maybe from someone's response, in addition to the standardized metrics, I think would be helpful. I think we need to do a better job, boots on the ground all over the state, figuring out where these pockets of intervention are. We need to find these communities and talk to them. And I think collaborations between universities and community-based organizations, like small grassroots organizations, are going to be important. Funding from the state to help these collaborations exist, because grassroots organizations don't have money to fund an organization like a university to come and run an evaluation for them. They're going to need funding for that, right? So that we can write up what they're doing in a way that can be amplified across the literature so people can actually replicate it. They don't have the funding for that. And I think we need to fund initiatives like that. We need to fund collaborations like that so that they can have their work documented. Nicole, I don't know if you want to add.
I think actually you touched on all the points. The only thing I would add is that a lot of the funding sources, like the NIH, prefer quantitative data. And so you usually have to have the qualitative data as, a secondary, or a supplement to the quantitative data. So it's kind of counterintuitive, but I think, participatory action research or community-based participatory research are really great ways, and they are, systematic. And the more people that use them, hopefully that can move the needle with these funding sources as well.
Well, thank you so much. We're unfortunately out of time, so we would like to thank our panelists for the insights and the knowledge that you shared. And just to conclude, social determinants of health usually fall under three categories. Healthcare system interventions. These are interventions that screen and assess patients for social determinants of health and either connect the patient to community resources that address those needs and alleviate the conditions, or attempt to address those needs in-house and on-site through partnerships with community-based organizations to ensure that these needs are met. The second type of interventions are community-based interventions that strive to improve health outcomes by implementing cross-sector strategies and recognize that our health is significantly influenced by our zip code. So they try to integrate health programs with social services in the community through cross-sector collaborations. The third type of interventions are non-health policies and practices, where there's an attempt to improve access to public transportation, access to sustainable wages and employment, nutritional programs like farm-to-school programs, community gardens, childcare, and early child education programming to address the gaps. In advancing any of these types of interventions, policies play an enormous role, as we heard today. We are making headways in these areas, but a lot remains to be done. Compliance with the culturally and linguistically appropriate standards class remains a challenge. Poverty alleviation interventions, which really is an umbrella for many of the ailments and the determinants that our speakers talked about. It remains really a Band-Aid measure that does not sustainably address chronic disinvestment in communities. So we need stronger public policies that address those structural and systemic barriers and resolve decades of disinvestments in poor communities, as poverty is a very strong social determinant of health. Place-based initiatives would address disproportionate burden of poverty on communities and would intervene in community disorganization and fragmentation. They would provide us easy access to community health facilities, address environmental health hazards that we talked about today. It disproportionately affect poor communities, and provide really safety net for all, address and end food deserts and food insecurity, create workforce programs that strive to comprehensively address the phenomenon of de-skilling, which immigrants are particularly vulnerable to, and really create policies that integrate health considerations and connect healthcare and social and human care services. So we need that sustainable and consistent infrastructure that does not really come and go depending on whether we have funding or not. On the positive side, we have assessment of community needs. It's becoming more and more an expectation, an expected practice that are mandated by the ACA. We are breaking down silos more and more. Health in all policies approaches are being advanced, where healthcare considerations are mainstreamed into decision-making across policy areas. We're creating work groups, task forces, and coordinating more effectively. We're having more regional and local entities advancing the goal of creating healthy neighborhoods with formal infrastructure, integrating health and social services. Again, as our distinguished speakers said, at the state and local levels, there are a lot of innovations that really treat or strive to treat every individual as a human with dignity and respect. The advanced medical home model emerged as a means of linking health and social services needs and address a wide range of individual needs, including social, economic, and environmental. So again, thank you so very much for our speakers today, and thank you all for participating in the webinar. We are deeply grateful for the speakers' insights and knowledge, and we wish you all a wonderful day ahead. Thank you for joining us.